The majority of patients that we see come in with just back pain. And unfortunately, back pain is a very common entity that we see. Not all of those patients are surgical patients. In fact, I would say the majority of them are not surgical patients. The ones that we do see that are surgical patients are one that have some type of deformity in their back, some vertebrae sliding on top of the other, or they develop some neurological complaint, which typically is pain or numbness going into their legs.
Things like infections or cancers of the spine, we definitely need to treat those. But more commonly, it'd be patients that have things like a disc protrusion or extrusion that's pushing on a nerve, or people that just have narrowing of the spinal canal or spinal stenosis. And when they have imaging signs that match their clinical symptoms, surgery is often a very excellent treatment for them and can offer them very good relief. Well, here we have a very team-based approach that I think benefits the patient. There's a lot of continuity of care.
We typically send our notes and a letter of some sort back to the primary care physician, letting them know what we saw and our plan. As the case goes on, or if we get to a point that we're doing surgery, the patient has to be cleared by their primary care physician from a health standpoint that they're okay to do surgery.
And then in the post-op period, it's important that the primary care physician know what the surgery was, if there were any complications, and what our plans are for the future. So when a patient needs surgery, we go over in detail what the surgery is. I typically use a spinal model to not only show them what the pathology is or what's wrong, but also to show them what our planned surgery is. We also go over their imaging studies in great detail. I really want to make sure that the patient understands what's going on. I also try to use really simple language that they would be familiar with. It's one of my pet peeves when doctors use words that patients don't understand.
Every surgery has risks. That's why we try to do everything conservative first to avoid that. And so typically we have models in the office, both of just standard spine models, but also of the instrumentation if we are doing a fusion, so the patient can actually feel it and hold it and get an idea of what's going to be put into their body. We run through all of their films and do our best to explain to them what the case is going to entail, what the post-operative care is going to entail.
Then right before the surgery, the patients report to the hospital and we see them, and we make sure everything is in order, and we answer any last-minute questions that they have. And we typically mark the surgical site so everyone's on the same page, and then we proceed on to surgery.
Most patients, a lot of our laminectomies are discectomies, so these are very, what we would consider minor procedures.
And the patients do very well, and they often feel more comfortable when they can go home and rest in their own bed. Some of the procedures we do are a little more involved, and the patients do end up staying in the hospital for 1, 2, maybe 3 nights, depending on what the procedure is.
We see our patients usually that night, the next day, and every day that they're in the hospital, which is kind of unique for surgeons. The way that we have it set up here at Mayo, we're able to do that. We like to see our patients, make sure that everything's going okay, and make sure that the surgery was successful and all their needs are being met.
The immediate post-operative period, we really want patients to focus on healing. And that means that they don't lift, bend, or twist excessively. Typically, we do put a lifting restriction on them of about 10 pounds for the first 6 weeks, and then maybe up to 25 pounds in the next 6 weeks, depending on how things are going. And really the purpose of that is to take pressure off the spine and allow things to heal.
The idea there is that we've either taken a disc out, we've fused it, we've done something that we want to give it a chance to heal over. And so it's very important to follow the weight restrictions that we give you. We hold off on physical therapy for 4 to 6 weeks. And the reason is that we just essentially put a hole in your back, and so you got to give that time to scar over and heal. If we start doing too much too soon, it'll just cause inflammation and cause you to have more back pain.
I think there's a number of reasons that someone would choose to have their spinal care here at the Mayo Clinic Health System. I think first and foremost is our concentration on our core value that the needs of the patient come first. And many of us here in our department trained at the Mayo Clinic in Rochester and really truly do believe in those values, and that comes out in our everyday practice. Another reason someone might choose to come here is because of the breadth of spinal surgery and expertise that we offer. We offer everything from minimally invasive spine surgery to complex deformity correction surgery, as well as revision surgeries for the spine.
Our team is made up of some excellent surgeons. Myself and Dr. Schiefer trained in Rochester, did spine fellowships in Rochester. Dr. Perez does minimally invasive surgery. We do everything all from the back, so the patients get home earlier, they recover faster, they're back to work faster, and this is really evident with the minimally invasive work that we do.
One way our practice model differs from some other practices is that we don't make any more money whether or not we operate on the patient or what type of operation we do. Our surgeons and our nurse practitioners are salaried, so we have no incentive to do an inappropriate surgery or to maybe do more surgery than somebody needs. So we really put the needs of the patient first and only consider that when we make our decisions whether or not to operate on the patient.